Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based out of DRC. Dr. Ngashi is also a principal advisor to the Director General of Africa CDC. I will now hand over the floor to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon, everyone, depending on which part of the world you find yourself. We are pleased again to come back to you to give you an update on the situation of outbreaks on the continent. I'm going to do it on behalf of the Director General, Dr. Jean Kassea, who couldn't make it today because of other pressing commitments. But during this brief, we'll talk about Mpox. We'll also talk about cholera. And I think the good news is that the integration is going on. We are now moving toward really expanding the IMST to be able to integrate also cholera. So we have one single structure on the continent that manages our outbreak with all the partners working hand in hand to ensure the complementarity of our effort. I think if those, Director, if we can then go through the slides. Yes, no, I would like to start with some of the important engagement of the Director General. First of all, with the visit of the 3 ambassadors from China, from Qatar, and from Tanzania, where they discuss ways they can strengthen the collaboration on health, and also they can work together to strengthen the continental health security in collaboration with Africa CDC. Next. The Director General also attended the RESCO meeting in Lilongwe, which was joined by SADC ministers of health, but also regional health leaders to discuss issues of cross-border collaboration and also the strengthening of public health systems. I think among the top topics, I think in the discussion, it is the investment in key pillars of our pandemic prevention, preparedness, and response, which includes surveillance, local manufacturing, laboratory capacity, and innovations in digitalization. And also it was a very important meeting also where voices came strongly to emphasize on solidarity and the shared accountability, that are critical for us to fight the challenges we are facing health security together as a continent. Next. Very important to also mention an important partnership that was launched on what we call the Mpox and other outbreak testing and sequencing in Africa, PAMTA, which is a collaboration between Africa CDC and ASLM, HERA, and ADEA, which focuses on, first of all, decentralization of lab molecular capacity and also the genomic surveillance across Africa. It also has a component on the acceleration of the local manufacturing of diagnostic tests. Or that, if you remember, it's one of important legacies of the Mpox response, where we really aim after this outbreak to leave much stronger capacity in laboratory diagnostics and sequencing on the continent to get better prepared for future outbreaks and pandemics. Next. Now, coming to the public health event, just as an overview, we like to just share that we have the same top 4 diseases that have been reported on the continent. with cholera coming first in terms of number of cases. It affects 23 countries and 198,405 suspected cases, of which 6,000 confirmed. And out of all the suspected cases, we have 4,222 deaths that have been reported. And then the second is the Mpox that we are going to talk about in details, affecting now 25 countries, and also measles affecting 18 countries, and dengue that also affect 10 countries. I think those are the most important public health events that were registered between AP Week 1 and AP Week 29. But when we look at the summary of those events in comparison with the year 2024, where we recorded 219 events of moderate and high risk events, now for the first 29 weeks, we have reached 147 events in total. That shows clearly that this year, once again, we'll maintain the upward trend and go beyond the 219 that were reported last year. But when you look at them also broken down of the high event, we had 72 last year. We've already reached 45 this year. And on the moderate event, we had 147 in 2024. Now we've already reached 102 in 2025. Next. Now coming to the Mpox situation in Africa as of week 29, I think what we see is that there is still a high number of new suspected cases that was reported, with a very slight increase of 1%. But where I would like to attract your attention is on the number of confirmed cases that have gone down 27%. That's from 755 confirmed cases in week 28, and now 553 in week 29. And also, there were about 16 countries that reported out of the 27 that affected. That's in comparison with 18 countries that reported the week before. But very interesting is when you look at the total numbers, we can see that on the suspected cases, we have now reported from the first week up to week 29, more than 91,000 cases, which represent 114% of the cases in 2024. That means that we are really geared toward reaching double or exceeding double the number of suspected cases this year. We see the same trend when it comes to confirmed cases, more than 28,000 already reported, representing 144% of all cases that were reported in 2024. But when you look at the dates, I think that's where we see a much higher increase of 420%, an increase from 45 dates that were reported last year among confirmed cases to 189 this year. But most of that could be attributed to the improvement in mortality surveillance that has happened in 2025. But across the board, what we see is that we see a continuous decline in the number of cases, both suspected and confirmed cases across the continent. And when we compare with the peak week 29, peak week, which was week 19, we see that we have seen a sharp decrease, about 66%, in the number of confirmed cases across the continent. I think that is good news. That really confirms that the cases are going down. At the same time, also, we are pleased to say that we've seen also an increase in testing coverage when we compare the last 6 weeks with the 6 weeks before. We've passed from 39% to about 65% on the continent. Now, that's the reason why, looking at where we are now, it is really time for us to maintain the current strength of strengthening community-led surveillance for early detection but also continuing the targeted vaccination, especially in hotspot settings. And we will continue also to improve on the integrated case management, especially when we see that most of the deaths, at least half of the deaths in some of the countries, is also attributed to co-infection with diseases such as HIV. Next. Now, looking at some of the countries that are reported cases of late, we have the Gambia that reported its first case on July 11. Since then, no other case has been confirmed, but there have been 71 suspected cases, but all of them have tested negative. We are dealing with clade 2. And the case was identified in Kombo North District, which is about 10 kilometers away from the capital city of Banjul. And that's the only active case. The contact listing had been undertaken, but only 6 contacts were identified. That's also because of the challenges related to the patient herself. But very interesting that there has been no documented history of travel out of Gambia in the weeks before the appearance of symptoms. That also leads us to then ask ourselves if there is a chain of transmission that remains undetected in the Gambia. I think work is being undertaken under the leadership of the Ministry of Health. To not only develop the Mpox plan that they have developed, also establish the surveillance system in place, most importantly, also cross-border collaboration. And in addition to that, I think the main challenge that is in the Gambia right now is the lack of funding. But that's why it is extremely important at this stage that we really intensify the early response to make sure that cases do not explode in the context of limited resources. Next. In Uganda, we have observed the continued downward trend, both in the number of cases and also in the number of confirmed cases. When we compare week 28 with week 29, we see a 42% decline in the number of suspected cases and 35% decline in the number of confirmed cases. We are still dealing with clade 1B. And when we look at the gender distribution, males make 42% of the cases. When we look at the age distribution, children make about 12% of cases for the children below the age of 15. Now, on the testing side, the testing rate remains very high, about 100%, meaning all the tests, all the samples that are brought to the laboratory are being tested and the results given back. We see good progress also on the test positivity rate that has declined from 67 in week 28 to 48 in week 29. That also a sign that the active surveillance is now working. The turnaround time on the result is at 67 hours. And in total, they do have 88 active cases in Uganda that are being followed right now. But when we also compare the overall trend with the last peak week, which was week 26, in Uganda, we see that there had been a decline of about 69% reduction in the number of cases in that country. I think that is very much encouraging. And also encouraging when we see that the same trend is observed with the test positivity rate that has also gone down from our 62 to 48%. I think the concern still remains the comorbidity and the fact that 50% of all those that die are HIV co-infected, and that we see the outbreak now mostly concentrated in 3 areas, which are Kampala, Wakiso, and Mbarara City. Next. Now, the situation The situation in the DRC also follows the same trend that we see across countries, is a downward trend. Although the number of suspected cases remains high, but we see a sharp decline in the number of confirmed cases, 42% between week 28 and week 29. And also the number of deaths now also low at only one death that was recorded in week 29. But of great concern in the DRC is now the new clade that was identified as clade 2B, identified in a patient that had a history of travel to West Africa. But when you look at the gender distribution, 69% are males. Children on the age distribution, children below 15 make 15% of all the cases. On the testing, we see some improvement that is starting now in the DRC. The testing coverage is at 50% now, and the testing rate is at 83%. It's more on the positivity rate that we've seen a slight increase from 35% the week before to 46%. But we know that DRC is one of the countries where active surveillance is being also strengthened with the involvement of our community health workers. In terms of the total number of active cases in DRC come to 845, and in total, more than 92,000 contacts that have been listed, but the concern remains on the ratio. I think that has remained low at 3 contacts for every confirmed case. Now, in summary, what we see is that the decline is being sustained among both confirmed and suspected cases in the last 8 weeks, as we can also see that on the epi curve, on the graph on the epi curve, we see that downward trend that has been maintained, and we all hope it continues like that. And very encouraging is the fact that that is happening while at the same time the testing is improving. I think that's good news. But I think the detection of the circulation of clade 2B in Kinshasa is something that is of great concern, really, and also raises questions about all the efforts that we are doing on cross-border surveillance that need further strengthening, and also rethinking the best way that we can strengthen that. Next slide. In Sierra Leone, the situation also remains kind of stable towards the downward trends. We have seen over the last 2 weeks an increase in the number of suspected cases and also the number of confirmed cases, about 16% increase in suspected cases, almost 20% increase in confirmed cases. But it is important also to mention that this is the result of the recent intensification of the response in Sierra Leone with the activation of the active case surge at community level that was launched 3 weeks ago. I think in a way, this was expected, that with the active surveillance kicking in, we expect for 2 to 4 weeks to see an increase before we can then see the decline once most of the cases have been identified and brought into the system for isolation and case management. Now, in terms of the disaggregation of those cases, I think we are still dealing with clade 2B across the board in Sierra Leone, but males make 52% of cases and children below 15 make only 5% of cases. On the testing side, Sierra Leone is doing very well. We have 100% coverage rate, 100% testing rate. It is more the positivity rate, which is of great concern now. But with the activation of the active case search through community health workers, we expect that positivity rate to start now going down in the coming weeks. In total, there are 247 active cases and 14,599 contacts that have been listed since the beginning. But it is important to say that 53% of those contacts have already completed the 21 days of follow-up. And also, Sierra Leone just did a mass vaccination recently that has been completed with more than 135,000 people, I think, that were reached. And now they have also received additional doses of vaccine, and we hope that they will continue now strengthening the ring vaccination around confirmed cases. Next. The situation in Malawi remains also to be followed very closely. Still low numbers, but we have seen an increase between week 28 and week 29 from 11 suspected cases reported to 14 during the week 29. But most interesting is on the number of confirmed cases that have tripled from 3 cases the week before to 9 cases during week 29, but there was no death. And looking at the clade that is circulating, it is 1B. And the distribution by gender, males make 74%. The distribution by age, children below 15 years of age make almost 15% of all the cases. On testing, Malawi is doing also very good, just like Sierra Leone, 100% testing coverage, 100% testing rate, with test positivity around 64%, which is just a sharp increase. But really, that is something that needs to be followed closely, and especially the trend during week 30 and week 31, because the test positivity was much lower before that, around 27%. The test turnaround time is very good at 48 hours. And in terms of the number of active cases, there are 14 that are now active, with about 679 contacts that have been listed. I think just to say that Malawi has got really a contact confirmed case ratio at 12 contacts for every confirmed case. Now, what we see there, it is really good testing coverage and good testing rate, which is very good. And also, we are seeing the sustained community transmission now that is kicking in with the continuous increase in the number of cases that is observed in week 29. But important also to say that we see improvement also in active case search, which can explain why we are seeing these numbers that are picking up as expected, with the training of community health workers that have added actually to the body of the human resources that are supporting the response in the country, especially to strengthen one of the weakest pillars of the response since we started, which has been surveillance. Next. And because of that, I think we have been also working with the government to support then the training of community health workers in the most affected district. I think the Director General had an opportunity to visit Malawi and also provide that support to the Minister of Health. I think just to know that this is a top priority for Africa CDC as part of the scale-up of the head of state commitment to recruit, train, and deploy 2 million community health workers that are now at the center of our effort to strengthen primary health care as a way of really boosting the human resource capacity to support both the universal health coverage on one side, but at the same time also the health security in the management of outbreaks, like it is the case now with Mpox in Malawi. Next. On vaccination, 11 countries so far have received the vaccines, and 8 countries are vaccinating. That's about over 3 million doses that have been shipped to the countries cumulatively. But we have more than 938,000 doses that have been administered. Also important to say that with the recent allocation Zambia is scheduled to receive its recent allocation today. I think we are following that up with the country to know if the vaccines have already have arrived. But it's also important to say that after we've gone through a period of where we had no vaccines, now we received the new allocation from the US government, 249,540,000 doses in total that have been distributed to 7 countries with active Mpox transmission. Next. Those countries are the ones that are here, Uganda, Sierra Leone, Liberia, Ghana, and Malawi. I think those ones have received the US government doses, estimated at 219,540. And then we have 2 other countries that have received vaccines from Gavi UNICEF, about 30,000, of which 20,000 to Guinea and 10,000 to Zambia. Next. Yeah, and also when we look at the number of doses that have been distributed that I mentioned, over 3 million doses that have been received in the countries. We have over 938,000 that have been administered, but we do have some balances, of those vaccines, with DRC having most of that balance, over 390,000 of MVA and 1.5 of the LC16. I think that's what makes the almost 1.9 thousand doses that are in the DRC. But other countries also like Uganda, Angola, Rwanda also do have some leftovers. I think that can help them as we move forward with the ring vaccinations around confirmed cases. Next. Now, we can now switch to cholera before we finish. Just to say that the number of cholera cases has continued to increase. Just remember that we've seen that trend since the year 2022, where at over 100,000 cases per year. Then we reached 224,000 in 23. In 24, we moved above 250. And now, just from week 1 to week 29, we've already reached 205,000 cases of cholera. Definitely, it is clear that this year we are going to end up with much more cases than we had the previous 3 years. And also important to say that on the death side, the case fatality is high. It stands at 2.1% in 2025. It was 1.9% in 2024, saying that we are still dealing with a high case fatality rate far above the 1% that is WHO recommended. But I also wanted to say that there are 2 new countries that declared cholera outbreak. That is Chad and Congo Brazzaville. They are to say that cholera continues to spread. This is also where we need to take forward the call to action that came from our head of state at the beginning of the month of June. And already we can say that that is being taken forward as our champion on cholera, the president of Zambia, might be launching this month of August the Continental Cholera Outbreak Response Plan. I think that will also intensify the support that countries receive to be able to control the cholera outbreak on the continent. Next. Yeah, the situation of in Congo, the outbreak was declared on the 10th of July. That is 3 weeks ago. By July 26, there were 124 suspected cases and 2 confirmed cases. But the most important is the number of deaths reported so far, very high, 20 deaths out of the 124, giving us a case fatality rate of 16%. But who is affected? Males make 50% of the cases and 51% of the deaths. And people below 20 make 35% of all cases and 35% of all deaths. But very important to also mention, if you look at the map, that the cases are coming out of two districts, the district of Mbamu, which is in Brazzaville, and the district of Mosaka, which is towards the north. And all of them bordering the DRC, and all of them also by the Congo River, which might explain also the risks that is also related to the unclean water from the river. And then secondly is also to say that some of the main drivers that are known, in addition to the cross-border transmission, it's also the poor wash facilities, in those districts that remain, I think, one of the main contributing factors in many of the African countries. Next. In Chad, the outbreak was also declared on the 13th of July, almost around the same time with Congo-Brazzaville, just 3 days after Congo-Brazzaville. As of July 25, there have been 49 cases that are suspected cases reported and 2 confirmed cases, with a case fatality of 80%. Although it is half of Congo-Brazzaville, but it remains still very, very high. Now, in terms of the distribution, females make 55% and persons below 21 years of age make 67%. And the drivers of the outbreak remain similar to what we have in Congo, is the cross-border spread, but this time Chad is bordering Sudan. The cases are towards the Sudan border, and also the poor wash infrastructure in the affected district. Now, but one thing to also mention here is that in the case of Chad, the cases are concentrated in an IDP camp, in a refugee camp in Dugui. That is where most of the cases have come from that place. It's a camp that is hosting about over 93% refugees since the month of April. And the system is really overwhelmed, as you can imagine, that the facility and the infrastructure also hosting those communities is not up to the standard. I think that's one of the main drivers of this outbreak experienced in Dugui. Next. In the DRC, we can also see that the situation is still on the upward trend. During week 29, there were 2,121 cases that were reported compared to 1,820 the week before in week 29. And also the number of deaths at 95, which brings the case fatality rate to about 4.5%. And again, that although it is maintained to the same case fatality rate reported also the week before, it remains extremely high. Now, on the main highlights, I think just to say that 82% of all the cases in the DRC over the last 3 weeks come from 5 provinces of Chopo, Sud Kivu, Kinshasa, Maniema, and Tanganyika. And some of the drivers of the outbreak, in addition to the cross-border spread that we mentioned and the weak wash infrastructure, I think DRC has also experienced flooding. I think that was reported recently in Kinshasa, and also the increase in water contamination in the provinces of Sud Kivu and Tanganyika as contributing factors to the spread of the cholera outbreak. But it is important to say that there's an increase in the number of cases and deaths that was observed, I think, the last week, week 29, compared to the week 28. But the good news is that there's vaccination, I think, that is going on in 11 health zones in 4 provinces, in Tanganyika, in Maniema, in Okatanga, and Chopo. And that vaccination has also been completed in the 2 provinces of Kinshasa and Sud Kivu. I think work has to be done because there was a water supply disruption, I think, in many areas, also in North Kivu, in the city of Goma, that also raised some fears of again seeing an increase in the number of cases in that province as well. And then in summary, I think we say that we have seen a sustained decline in the number of Mpox cases in the most affected countries. I think those are DRC, Uganda, Burundi, and Sierra Leone. And in addition to that, we also see an increase in the testing coverage, across the board, which then also gives us some assurance to say that this decline that we see might be the actual result of all the effort that these countries have put since the declaration of the public health emergency. In addition, it's also important to mention that with the involvement of community health workers and the deployment of epidemiologists, we are seeing some improvement also in the community surveillance, especially the active surveillance that is also kicking in all these countries. But concerns remain. We have new countries that are reporting cases. We have the Gambia that we mentioned, we have Cameroon, we have Mozambique, that also indicates that there is still that persistent regional spread, of the Mpox across the continent. I think the second plan had already started the intensification of the response. It is clear that with this trend, we just need to maintain really the foot on the accelerator to continue the intensification to see more progress toward the control of this outbreak. At the same time, we see also cholera that is kicking in, and the spread also happening to new countries like Chad and Congo-Brazzaville that we just reported. But this is also the time that we can say that the integration has been activated to ensure that both Mpox and cholera are managed together, not through integration in coordination, but also in the response. And that we have now the continental cholera response plan that is being finalized, that is going to be launched in the next few weeks in Zambia by our continental champion, who is the president of Zambia. I think that's it, the essence of what we wanted to share today, Director. I would like to thank everyone for the attention and also open it up for comment and questions. Thank you.
Thank you, Dr. Ngashi. Let's cross over to the floor. We have Richard Gorman. Richard writes for the Wiley Online Library. Richard, over to you. Richard, can you hear us? Richard, can you hear us? Okay, let's move on to Kemo Cham. Kemo writes for Mano Reporters. Kemo, back to you.
Hello, can you hear me?
Yes, we can hear you. Go ahead.
Thank you. I have two questions. One of them is like a clarification, that is on Guinea. You mentioned towards the end of presentation on Mpox about some allocations of vaccine, and you cited Guinea. So I wanted you to clarify what allocations are these, because in previous presentation, we are talking about 0 doses, and Guinea was one of the countries that didn't have. The other one is on Gambia. You mentioned something about the country not having money, resources to do certain things, in terms of its response. This is something that has come up in several other countries, which has affected the responses. It's like countries are, caught off guard and never prepared. But we are talking about a region where we have been dealing with emergencies like this for many years now, and we are being told that we should be ready, we should be expecting these things. What would Africa CDC say about this? Like, what is expected of countries? We are seeing new cases coming up in new countries. what should countries do to prevent situations like that? Thank you.
Thank you, Kemo. Back to you, Dr. Ngashi.
Thank you very much, Kemo, for those very interesting questions. I think on the first one about the Guinea allocation, I think the last round of vaccine allocation did set aside 20,000 doses of Mpox to Guinea. I think that's what I was talking about. Now, I think Guinea has got now the opportunity to also integrate vaccination in the package of the interventions that they're implementing to control the Mpox outbreak. And on the funding, I think there are two points I would like to make here on the situation in Gambia. This is a kind of common situation that is happening in countries because most of our countries do not have an emergency fund that is set aside to help them intervene immediately, even before partners can kick in. This whole question about day zero financing to deal with emergencies remains a very important one. On the side of Africa CDC, I think we are working on two fronts. One is that there's now what we call the AFEF. It is the African Epidemic Fund. I think that has been approved through the AU system by our continental leadership. That will allow Africa CDC to work with different partners and mobilize funding that can be made available to be deployed on day zero, to help our member state. But that's not enough. I think the other front we are also working on is to work with the member state to ensure that all of them do set up an emergency fund. Because in any emergency, as you see with what is happening with the global health financing crisis, that really the time of Father Christmas kind of approach is almost overdue now. I think we would like to see more of the investment of domestic resources. But at the same time, we also understand that we cannot let the member state pay the full price of the cost of an emergency. I think they need also time to create that fiscal space. But what is important is to have even an emergency fund, however limited it is, that can allow the country to chip in exactly when they still have fewer cases, while the partners and Africa CDC is also mobilizing through the African Epidemic Fund or through other partners to be able to come to the rescue of our member state. Back to you, Director.
Thank you, Dr. Ngashi. Let's take the next two questions. We have a question here that says, could you please elaborate on the expectations placed upon the Africa CDC and its member countries regarding the prevention, preparedness, and response to emergencies? Then the next question asks, how can Africa focus on evidence-based public health practices in the event of so many things uploaded on the internet? Back to you, Dr. Ngashi.
Can you please repeat the last one?
The last one is asking about how Africa can focus on evidence-based public health practices in the event of so many other things that are uploaded over the internet. Back to you.
Yes, thank you very much, Director, and thanks also to colleagues for asking those questions. First of all, on the question of pandemic prevention, preparedness, and response. I think there are a number of things that are happening, both globally and also on the continent through Africa CDC leadership and other partners also engagement. First of all, there are things that are critical to get the continent ready for the next outbreak or for the next pandemic that Africa CDC is working on. One is we are working in the area of surveillance, which is critical. I think it is the surveillance that will allow us to identify this pandemic or outbreak emergency rapidly and also respond. As you know that the sooner you respond, the higher the chances of success, the shorter the response, and the more efficient it is also your response in terms of how much it will cost you. That's the reason why that first step is one is extremely important. We're working on it through the surveillance, working on really strengthening the community-based surveillance. We just completed a study now on the continent that has shown that we have 1 million community health workers on this continent. We like to mobilize that army to also be the ones that are at the forefront of that community, trying to watch out for outbreaks, I think, that are coming up, to be able to pick them. But linked to that surveillance is also the work that we are doing on the digitalization of the primary healthcare to ensure that we have digital tools that are deployed to the primary healthcare facility, that are given to our community health workers out there, to be able to share that information in real time. That is one pillar. The second pillar was on the laboratory. As you know, that if you've read even the Mpox plan, we are talking about the decentralization of laboratory capacity as one of the legacy of the Mpox, to be able to prepare our member states for the next outbreak, because you should be able to make the diagnosis on time and also respond adequately. The third area we are working, it's also on really what we call the second independence of Africa, is on the local manufacturing of medical countermeasures. As you see, the way that we have really taken a lot of time and not to negotiate for the donations of Mpox vaccines. You also remember what Africa went through during the COVID-19. It's an important area that we are also working to make sure that if we can produce some of those medical countermeasures on the continent, both the diagnostics, the vaccines, and the treatment, I think that will help us really get ready to manage future challenges when they happen. I think, and also we are working on the area of financing that I've spoken about. You have heard what Africa CDC is doing on health financing, but on the pandemic specifically, this African Epidemic Fund is one we are also trying to really push forward to be able to get the resources that we need. And finally, it is on the stockpiling of these medical countermeasures. We are working toward establishing a continental warehouse that will really keep some of these commodities ready, to be just deployed to the member states whenever the crisis hit. That is what we can do on the continent. But at the same time, we are also involved in what is happening globally. You've heard about the pandemic agreement that Africa CDC has played a key role really to support our negotiators in Geneva, to convene them here in Addis, there to make sure that we can negotiate an agreement that also favors Africa. And even the remaining discussions about the pathogen benefit sharing, it's something that Africa CDC is also in the lead to ensure that that portion also of the agreement is adequately addressed in favor of the African continent. I think those are some of the things that Africa CDC is working on. On the evidence, in public health, I'm pleased to inform you that Africa CDC has convened the public health expert on the continent to be able to produce annually a report. We call it the Africa Public Health Intelligence Report, that can just capture the burden of disease of Africans. What is it that Africans are suffering today? What is it that Africans will be suffering from in 10 years? To cover the profile of our emergencies, what's the profile of the emergencies today, what's the profile of emergencies in 10 years, and then capture also the same on antimicrobial resistance. What is that we are dealing with today? How would that look like in 10 years? So that then that report will also present a chapter that just looks at what is it that we want, as medical countermeasures in Africa to be able to get this continent ready for those shocks that might happen in the future, and what are the priority research questions that are of concern for the African people. That is one thing, that is to produce that report then that can at least gather the consensus of our scientists around the priorities for Africa. That's the way that you put the evidence forward to guide the action. In addition, you also see the way that we are approaching emergency management. Mpox, for example, we have an entire pillar that is just focused on research and innovation to make sure that as we are responding, we also have the research that can support the way to generate the evidence that can then feed into the response. We gathered more than 2,000 African researchers just to identify the priority research questions that support Mpox. It's just a way that to show exactly the way we are working to ensure that our work is grounded in science and also in evidence. Over to you, Director.
Let's cross over to the floor. We have Esther Nakazi, a science journalist based in Uganda. Esther, you have the floor.
Thank you, Margaret, and thank you, Dr. Ngashi. I just want to follow up on the Africa Epidemic Fund. How will it be financed? I could have missed that. And how is this financing going to be sustained over the long term? And what would you say about the governance and accountability mechanism that is going to be put in place for the fund? Yeah, thank you.
Thank you, Esther. Let's take the next one before Dr. Ngashi comes in. We have a question on the cholera outbreak in other places in Africa. The question is, given the importance of effective communication in controlling outbreaks, what lesson from the Mpox and cholera responses are being applied to improve public health messaging and awareness campaigns across Africa? Back to you, Dr. Ngashi.
Okay. On the first question, I think on the African Epidemic Fund, how is it going to be funded? The strategy to fund that, I think some of the elements we can find them in the Africa CDC Green Paper, which is the health financing. I think it gives an idea of how we see the funding of public health on the continent, including the African Epidemic Fund. It will be a true member state contribution. It will be also through the innovative financing and also the contribution of partners, I think, that are also willing to contribute. It's through those three different vehicles that will mobilize funding for the African Epidemic Fund. Now, on the governance of it, it will operate as a board, as a trust which has got a board that is on one to ensure the independence, and credibility of the management of the AFF. But next to that also, we will also be channeling its management also through the governance structures of Africa CDC. That has got the governing board of Africa CDC that would also oversee that. It is made of health ministers from 10 countries representing the 5 regions of the AU. That's 2 ministers from the north, 2 ministers from the south, 2 ministers from the east, 2 from the center, and 2 from the west. We have the governing board that is operational, that guides the work of Africa CDC and all the policies and decision. In addition to that, we have the Committee of Head of State, which is also made of 10 head of state, including the 5 sitting Bureau of the African Union, and then 5 other presidents that represent each one of the 5 regions. I think that is this very robust mechanism that is put in place to ensure the transparency, and credibility of the governance of the African Epidemic Fund. Now, the second question, Director, can you repeat it again?
So the second question was on the importance of effective communication in controlling outbreaks. So what lessons have we learned from the Mpox and cholera responses that are being applied to improve public health messaging and awareness campaigns across Africa?
Yeah, do you want to respond to that? Yeah, I can start. I think one thing that we learned early in the Mpox response, which is also going to contribute also to the cholera response now, is that you need a combination of first of all strategies, in your communication. The traditional media still have their own value. I think there was a study that was conducted just to see what is the source of information, among the population that we are targeting, to also again support the previous lesson about the science and the evidence that are to support the response, it will show that really radio, TV still play a very important role, as well as health facilities. Those traditional channels do work. I think they still have their value. But at the same time, what we've also seen is the communication of the grassroots organizations and community health workers is also something that is extremely important. Extremely important because it gets into the people's home. It offers an opportunity to exchange, to also hear their concerns. I think that's also something that has been extremely useful. One good lesson in that is that as you run your outbreak, as you communicate, it is extremely important to have a mechanism of getting the rumors on one side, but also getting the feedback, the feedback from the communities as well. I think by doing this, those two vehicles have really helped us also tailor the message to the concerns of the community. I think it is the combination of that we think that the way as we move forward, maintaining those feedback loops, from the community that you are communicating to also get what they understand of your messages and what they are more concerned about. They would like to hear more from you instead of maintaining that the same message from the beginning of the outbreak to the end. I think those are some of the key lessons that we have learned, that you need that evidence that continues to be also exploring the effect of your communication and the growing or shifting needs of the community in communication to be able to also adapt your response. I could say that, Director, feel free if you want to add something on communication.
Yeah, I think you've raised valid points. I think the integrating risk communication and community engagement within the interventions, especially that we have done in DRC and other countries, has assisted in terms of engaging the communities and ensuring that we have community-centered messaging that reaches to the grassroots level, which assists the community to have that affinity, when it comes to, for example, vaccine efficacy and other interventions that are being done on the ground. So I think that's most of the efforts that we've done on the grassroots level. So the next two questions here, I have one on the stockpiles of oral cholera vaccines. Can you provide an update on Africa CDC's effort to build sustainable stockpiles of oral cholera vaccines to ensure timely responses in future outbreaks? And then the last one here is, can you explain why there is such a high case fatality rate in the cholera outbreak in Congo-Brazzaville compared to other outbreaks? Back to you, Dr. Ngashi.
Yeah, thank you very much, Director. Charles, you can perhaps take the first question on the cholera vaccine stockpile, and then I'll take the second on the high case fatality rate.
Yeah. Thank you so much, Dr. Ngashi, and thank you for that question. So currently, of course, there is a mechanism. There is an existing stockpile for cholera vaccines, of which we all know, that is the ICG, wherein countries availed vaccine depending on request and the dynamics of the disease in the country. However, what we are trying to do is to create now a more like another kind of a substitutional mechanism that will link up to the ICG using the IMST system to be able to come up with a mechanism that will also support countries in fast-tracking assessing of these vaccines. And within this measure, yes, there may be room to also stockpile vaccines to be able to assess vaccines with support from donors. However, for now, the stockpile readily available is that of the ICG. Thank you, and back to you.
Yeah, thank you very much, Charles. Just to also add to it that one of the things is also knowing exactly the quantities of vaccines that you need. We are working on the plan. I think we have the draft cholera continental response plan. that will also provide information on the estimated number of cases that are expected in the next 6 months. That will be the basis to also provide an idea on the demand and the needs, for vaccines for the stockpile. Now, the other question was about the high case fatality rate in Congo-Brazzaville. That is of great concern for us. When we also saw that 16%, we're really concerned. Even in Chad, 8%, we're very much concerned. Looking at it again deeply, it is the result of, one, the late care seeking behavior of our communities in those districts. And secondly, the health system readiness, to manage these cases. I think which is some of the things that we are also working on as a legacy. We like really all countries to have treatment centers, infectious disease treatment centers that are well equipped with trained staff, with all the supplies that are ready, that once there's an outbreak, they bring the cases there, then the cases are taken care of. It is the weakness of the health system that was not ready, and also the late care seeking, that explains the high case fatality rate that we see in most of our African countries at the beginning of an outbreak. As you are going to see that now that the response is going in, the community mobilization and engagement will go in, and then the isolation will be organized, the treatment will be organized, the skills will be built, the commodities will be also provided. You see now that case fatality starting to go down. But I also see, Director, there's a question in French, which is asking how can we invest in strengthening the capacity of health professionals, the frontline health professionals, to anticipate the response to public health emergencies, and also include even the psychosocial dimension as well in the period of crisis. I think that's the question that was asked. Just to say that as part of the preparedness of the system, the health workforce is an important component of that, and that we are working on really training programs. We had started already a number of programs for public health experts, with the African epidemic, the field epidemic training, or of the laboratory expert also. We have a training already in that side. Now we are moving toward also training for the community health workers in health security and emergency management, so that they are all prepared ahead of time with basic skills in surveillance, basic skills in risk communication and community engagement, basic skills in on IPC, infection prevention and control at community level, and basic skills in management. Things like cholera, I think for simple cases where there's no dehydration, I think they can be well managed at community level with ORS and zinc. I think those are the things that we are putting now together, a continental standard training package. I think that will include a module on our health security that will aim at doing exactly that, anticipating and building the skills and competencies of the frontline workers on that. But then the second leg that also need to be developed is not yet advanced. It is on the PHC. I think the primary healthcare strengthening, also the readiness of primary healthcare for emergency management. That's also where we'll see this, where we'll also build that capacity in every single health clinic, in every single hospital, to have a team that is already a multidisciplinary team that can do both the clinical management, the IPC, the psychosocial support, and the nutritional support, given the fact that in an emergency like Mpox, what we saw in most of those countries, that the multidisciplinary team included clinical case management, also psychosocial support, and also the nutrition support. I think that would be the second phase of that preparedness of our system on the continent, an area that is extremely important for Africa CDC and all the partners working on health security on the continent.
Thank you, Dr. Ngashi. We have a question from Radio France International on the malaria vaccine. The question is, what is your assessment of the new malaria treatment recently approved by Swissmedic named Coatem Baby, particularly in terms of its effectiveness and the challenges of introducing it across African countries? It was approved in early July. And what are the main obstacles to making this treatment widely accessible, especially in countries where resistance to current therapies is increasing? We understand that it has been rolled out in Ghana, with other African countries expected to follow soon. Did you get the question?
Yes, I see. I see it on the screen. Yeah, I think I have to say that this is very recent. It's a very recent development. It is in early July. At Africa CDC, we do have an entire department under the primary health care that is focused on disease control and prevention that deals with malaria. There's no official position yet because we haven't yet had that high level discussion. I think the team is still doing its own work. We can say that as soon as they complete the discussion at the center level, then they will come to management to then have that discussion and have a common position. And once we get that common position, we'll be more than happy to share it. But for today, as we are discussing, that hasn't yet come back to the level of management.
Thank you very much, Dr. Ngashi. And with that, we have come to the end of the weekly briefing this week. I'll hand over the floor back to you for your closing remarks. Over to you.
Thank you very much, Director. And I would like to thank everyone for making it again for another very interesting press conference. For us, it's always a great pleasure to feedback. We feel ourselves accountable to you. Now, we are encouraged by the results that we see. This declining trend on Mpox is very encouraging. We are also very much encouraged with the new development on the cholera front. Also, our leadership that is also stepping in to support the continental effort. But for us, the most important is this integration that was started already with the second plan of Mpox. It is critical. It is really visionary. It also comes at the right time as we are now talking about the declining global health financing, which then forces more efficiencies, and integration is really at the center of those efficiencies. I think we look forward really to continuing this approach to add more integration. And we also count that with the current effort and the current trend, we are very hopeful that very soon we'll see some light at the end of the tunnel. It is clear that we do not dream ourselves that we can control the Mpox outbreak today. It might take a couple of months, but what is encouraging for us is that at least the bending of the curve gives us some hope that we'll get there. We'd like to thank all of you again for making the time to be with us, and thank you for all these questions, including even the question that was asked on malaria. I think those are the questions that also guide us, in our work in terms of where some of the priorities are that we should be looking at as an organization. We look forward to meeting you again next week, same day at the same time. For now, we wish you all the best.